Welcome, everyone. Thank you for being here. Over the next hour and a half, we are going to do something a little different from the usual compliance session. We are not going to read part 211 back to you. You already know it. If I asked anyone in this room to tell me what the quality unit is responsible for, or what a thorough investigation looks like on paper, you could do it in your sleep. So that is not the gap. The gap, the reason FDA findings keep showing up year after year in the same categories, is the distance between what the procedure says and what actually happens on the floor, in the lab, and in the records. That distance is where 483 observations are born, and it is where this session lives. Here is the promise I want to make for the next 90 minutes. By the time we are done, you will be able to look at any FDA finding, yours, a competitor's, one you read in a warning letter, and read it not as a line item, but as a signal about a quality system. And more importantly, you will be able to turn that same lens on your own operation and judge honestly whether your system would hold up under inspection. One note before we start. Everything today is educational, drawn from publicly available FDA expectations and general industry experience. It is not legal advice, and the scenarios I will use are anonymized and illustrative. No company names, because the point is never the company. The point is the system. So if knowing the rules is not the problem, what is? Let's start by being honest about why the usual common violations training quietly fails. Let me start with a confession that applies to most of our industry. We love a good list. Top 10 observations, most cited regulations, the dirty dozen of data integrity. And lists feel productive. You can put them on a slide. You can circulate them. You can say you trained on them. But here is the uncomfortable truth. A list of common violations almost never prevents the next violation. Why not? Look at the 3 points on the left. First, your teams already know the rules. The people in your QA, QC, and regulatory functions can recite the relevant parts of 21 CFR Part 211. Knowing the regulation is rarely the thing that is missing. Second, the real gap is paper versus practice. A finding does not live in the regulation. It lives in the space between the procedure as written and the control as it actually operates. The step that gets skipped under time pressure, the limit nobody is actually trending, the review that has quietly become a signature instead of a check. And third, a 483 line is a symptom, not the disease. The observation an investigator writes down is the visible tip. The system weakness underneath it, the part that will repeat, is your real exposure. If you only fix the symptom, you have set yourself up to see it again. Now look at the card on the right, because this is the reframe that runs through the entire session. The question is not only, do we have a procedure? Almost everyone can answer that one, yes. The better question, the one FDA is really asking, is can we prove that procedure is scientifically sound, that it is actually followed in practice, that QA genuinely reviewed it, and that it is effective at preventing recurrence? Those are 4 very different claims, and most firms can only confidently make the first one. If a finding is really a signal about the system, then the smartest thing we can do is learn to read those signals. So let's reframe FDA findings as exactly that, system failure signals. Here is the mental shift I want you to make and hold for the rest of the session. Stop reading a finding as a mistake and start reading it as a signal. A mistake is about a person or a moment. A signal tells you something about the system that produced it. FDA reviewers think this way instinctively, and the firms that do best are the ones who have learned to think the same way about themselves. When you look across the findings that actually drive enforcement, they trace back again and again to one of 8 recurring system weaknesses. These 8 are the spine of everything we will cover today. Weak investigations, where the scope and the root cause stop short of the real failure mechanism. Thin quality unit oversight, where QA approves for completeness instead of adequacy. Ineffective CAPA, where the documentation changes but the failure mechanism does not. Inadequate process control, where the process was validated once, but the ongoing state of control is unproven. Then, laboratory control gaps, where out of specification handling, method, and review weaknesses erode trust in the result. Contamination control failures, where cleaning, maintenance, and environment are treated as separate boxes instead of one integrated strategy. Data integrity weaknesses, where the records simply cannot prove what actually happened. And finally, missed recurring patterns, where no single person owns the job of watching the same signal repeat across the site. Notice something about that last one, because it is the quiet killer. A single observation can be completely defensible. One deviation, well investigated, is just operations. But a cluster or a repeat tells FDA the system itself is not detecting and preventing failure. That is the difference between a finding and a finding with teeth. 8 weaknesses is a lot to hold in your head in the moment, so let me give you a simpler, portable tool. 4 questions you can run on any finding before FDA ever does. If you take only one tool home today, I would be happy if it were this one, because it fits on an index card and you can use it Monday morning. Whenever you are handed a finding, an audit observation, even a customer complaint, run it through 4 questions in order. Question 1. Control. Was there a real control here, or only a document describing one? Those are not the same thing. A binder full of SOPs is not a control system. It is a description of one. The question is whether something actually constrained the outcome. Question 2. Detection. Would the system have caught this on its own without an inspector pointing at it? This is the question that separates a mature quality system from a lucky one. If the honest answer is we only found it because they found it, that is a detection failure sitting underneath whatever was cited. Question 3. Investigation and impact. How far did the firm actually look? Did the investigation stay inside the 4 walls of this one batch? Or did it ask the harder questions? Related batches, other products, the same equipment, the same method, the same supplier? This is where most investigations quietly stop too early. And question 4, prevention. After all the activity, does anything actually change that lowers the chance of recurrence? Or does the exact same condition remain, now with a closed CAPA number attached to it? Look at the insight along the bottom. Mature teams run this lens on their own observations first, before anyone from the agency walks in. The firms that struggle are the ones who only ever see the 483 line item, and never the system question underneath it. The whole goal of today is to move you firmly into the first group. Before we dive into the systems themselves, let's ground ourselves in what FDA actually keeps flagging. A quick baseline of the territory, with one honest caveat about the data. Let's set a baseline. These are the recurring observation areas that come up in GMP inspections, each tied to the part of 21 CFR 211 that usually gets cited. Think of this as the map, not the territory. It tells you where to look, not what to do. And the what to do is the rest of our session. Quality unit procedures not established or not followed. That's 211.22. Discrepancies and failures not thoroughly investigated. 211.192, which will become our centerpiece. Production and process control procedures that are inadequate. 211.100. Laboratory controls that are not scientifically sound. 211.160. Equipment cleaning, maintenance, and contamination risk. 211.67. Computerized systems and data integrity weaknesses, which connect to 211.68. And microbiological or aseptic contamination control gaps, 211.113. Now, I need to be straight with you about the data, because this is itself a data integrity principle, and I would be a hypocrite to ignore it. You will see decks that quote precise percentages. 42% of 483s cite such and such. Be careful with those. FDA's public Form 483 observation data is directional. It reflects coded observations and tells you roughly where findings cluster in frequency. It is not a complete record of every observation or its context. So I am not going to give you false precision numbers, and you should be skeptical of anyone who does. Here is the line that matters most on this slide, and I want you to hold on to it. The deeper issue is rarely the cited regulation itself. It is almost always a failure of control, oversight, detection, investigation, or prevention sitting behind it. The citation names the rule the investigator could point to. Your exposure is the missing control behind it. That last point deserves its own slide, because the difference between what the citation says and what the system weakness actually is, that gap is the whole game. Let me put the two sides next to each other, because once you see this, you cannot unsee it. On the left is what the citation says, the language that lands on the form. On the right is what the inspection was actually about. Procedures were not followed. That sounds like a discipline problem, a people problem. But what it usually means is an execution and oversight gap. There was no designed trigger that would catch the drift before an inspector did. Nobody chose to ignore the procedure. The system simply had no way of noticing it wasn't being followed. The firm failed to thoroughly investigate. On the form, that's a paperwork criticism. Underneath, it's a scope, root cause, impact, or CAPA weakness. The investigation stopped at the convenient cause and never reached the real one. Laboratory controls are not scientifically sound. That reads like a lab problem. Usually, it's a method, sample, or data governance gap that QA looked at and never actually challenged. And the quality unit is inadequate. That's the big one. On paper, it sounds almost bureaucratic. In reality, it is a governance failure. QA had the authority to stop the recurrence, and for whatever reason, workload, timeline pressure, culture, did not exercise it. So here is the question I want to plant, because it leads directly into the next idea. Have you ever closed a finding by fixing the left column while leaving the right column completely untouched? Be honest with yourself, because that, precisely that, is how a repeat finding is born. I just used the phrase, how a repeat finding is born. Let's make that literal. Here's the exact chain by which one small signal becomes a repeat 483. I want to walk you through a sequence that you are going to recognize, because almost every repeat finding I have ever seen follows this exact path. And the reason it is so dangerous is that every single step in it looks reasonable on its own. Step 1, a signal appears. A deviation, an out-of-specification result, a complaint, a trend. Step 2, it gets treated narrowly, handled as a one-off event, this batch, this day, this analyst. Step 3, the investigation is shallow. It documents what happened, but lacks real scientific depth about why. Step 4, the impact view stays limited. Other batches and products are never assessed. Step 5, a weak CAPA, usually retraining or an SOP tweak, that does not touch the actual failure mechanism. Step 6, QA review becomes administrative. Approval means the record is complete, not that the fix is sound. And step 7, the repeat finding. The pattern returns, and now it carries real regulatory weight. Here is what makes this chain so resilient. Each link is individually defensible. You can stand in front of an auditor and justify every single step. We investigated. We took corrective action. QA approved it. All true. The failure is not in any one link. It is cumulative. The chain as a whole never broke the loop. And look at that dashed line feeding back to the start. Until somebody intervenes at the system level, not at the event level, the same signal comes back around. That is the loop. That is what repeat actually means. Read the strip at the bottom, because this is how FDA interprets it. A repeat event is treated as evidence that the quality system is not effectively detecting, investigating, correcting, and preventing failure. 4 verbs. Miss any one of them consistently, and the loop keeps turning. The obvious objection at this point is, but we have procedures for all of this. Fair. So let's tackle that head on. Why do repeat findings happen even when the SOPs exist? This is the slide that answers the most common pushback I hear. But we have a procedure for that. Of course you do. Having an SOP answers the question of existence. FDA is asking about effectiveness. Those are different universes. And here are the 6 places where a fully documented system still produces repeat findings. First, the SOP describes the step, but not the proof. It tells you what to do, but not the decision logic, and not the evidence that the control actually worked. It documents the action, not the assurance. Second, detection depends on a person noticing. There is no designed trigger, no alert, no trend limit that fires on its own. So catching the problem comes down to whether the right human happened to be paying attention on the right day. That is luck wearing the costume of control. Third, investigations close on the convenient cause. Root cause lands on whatever closes the record fastest. Analyst error, isolated event, rather than on what the evidence actually supports. Fourth, the CAPA changes paper, not mechanism. A revised form, a memo, a retraining. Meanwhile, the physical and procedural conditions that produce the failure are completely intact. Fifth, QA confirms completeness, not effectiveness. The approval verifies the record is filled in, every field populated, every signature present, but never asks whether the fix reduces recurrence risk. And sixth, the one that ties it all together. Nobody owns recurrence across the site. No single person is watching the same signal repeat across batches, products, lines, and sites. So the pattern is invisible until an inspector assembles it for you, which is the worst possible way to find out. The 2 I see most often, by far, are detection by luck and CAPA that changes paper. If you fix only 2 things after today, make it those 2. 5 of those 6 failure modes pass through one function. So let's go to the root of most GMP failures, the quality unit. We are now into the heart of the session, and we start where the agency very often starts, the quality unit. I want to be careful here because this is not about blaming QA professionals, most of whom are heroically overworked. It is about understanding why, structurally, the quality unit sits at the root of so many findings. Start with authority and responsibility. 21 CFR 211.22 gives the quality unit 2 things: the authority to approve or reject components, procedures, specifications, and finished product, and the responsibility to make sure procedures are actually followed. Authority and responsibility. Hold those 2 words. Now the common thread. When you see investigation findings, CAPA findings, and release findings clustering together at one site, the shared root is very often the same. QOA had the authority to stop it, and for some reason did not. Not because anyone was negligent, usually because the review had drifted into something administrative under pressure. And that is why FDA frequently treats a quality unit observation as the parent finding, the one sitting upstream of all the others. Look at the diagram. Investigations, CAPA, batch release, process control, laboratory, data integrity. Every one of them passes through the quality unit. So when several of those go wrong at once, the inspector's natural question becomes, where was the quality unit while all of this was happening? That is the structural point. QOA is the hub, which means when QOA review weakens, it does not weaken one spoke, it weakens all of them at once. So if the quality unit is the hub, the critical question is what QOA review actually does in practice. And the honest answer at most sites is that it has quietly drifted from preventive to administrative. Let's look at that drift. Here is the single most important distinction in the entire quality unit conversation, and it has nothing to do with effort. It is about what the review is actually doing. On the left, administrative QA. On the right, preventive QA. Administrative QA signs for completeness. The record is filled in. It confirms the boxes are present, but not that they are sound. It closes items because they are overdue and the metric needs to look good. And it treats batch release as all documents are complete. Every one of those behaviors is understandable under deadline pressure, and every one of them is a quiet step away from real control. Preventive QA does something fundamentally different. It challenges a weak or convenient root cause instead of accepting it. It verifies that the impact scope actually reached far enough. Did we look at the other batches, or did we just say we did? It tests whether the proposed CAPA will genuinely change recurrence risk, and it treats batch release as a documented risk judgment built on evidence, not a clerical confirmation that the paperwork arrived. Now I want to put the self-assessment questions in the dark box to your own quality unit, and I want you to answer them honestly, not defensively. Can QA prove, actually show an investigator, a case where it pushed back on a weak investigation? Are repeat deviations genuinely escalated or quietly reclosed? Is batch release a real risk judgment or document completion with a signature? Are CAPAs approved because they are scientifically adequate or because they were about to go overdue? And does QA actually see recurring risk across departments or only within silos? Then the question at the bottom, which is the one I would ask if I were the investigator. On your last 10 batch releases, show me where the documented risk judgment is, not the signatures, the judgment. If it is not visible in the record, then from the outside, it looks exactly like document completion. Of all the spokes coming off that QA hub, one breaks more often than any other, and it is where we'll spend the most time today: investigations and CAPA. This is the centerpiece of the session, and I'm going to ask you to lean in here. Because if there is one area where I see quality systems look strongest on paper and weakest in evidence, it is this one. The foundation is 21 CFR 211.192. It requires a thorough investigation of any unexplained discrepancy or any failure of a batch to meet its specifications, including documented conclusions, follow-up, and a determination of whether other batches or products are implicated. Notice the word thorough. That single word carries enormous weight, and FDA's expectations around investigations make clear that thorough means the investigation has to actually reach related batches and products where the evidence points that way. Now, look at the flow on the right, because this is the mental model I want you to carry. Signals enter the system. Deviations, out-of-specification results, complaints, batch failures, they all funnel into one place, the investigation. That is the hinge. And out the other side comes the CAPA and its effectiveness check. That is prevention leaving the system. Here is why the hinge matters so much. The quality of that single step, the investigation, determines everything downstream. If the scope is too narrow, the impact assessment is wrong. If the root cause is convenient instead of correct, the CAPA aims at the wrong target. Get the hinge wrong, and no amount of downstream activity saves you. This is where root cause, impact, and prevention either come together or quietly fall apart while every form is filled in perfectly. And the single fastest way to recognize a weak investigation: 2 phrases. If you see them, your antennae should go up immediately. Let's talk about operator error and retraining. I am going to pick on 2 phrases that appear in a remarkable share of weak investigations, because FDA reviewers are absolutely primed to push on both. And so should you be on your own files. First, operator error as a root cause. Here is the problem. Operator error is a description, not a root cause. It tells you who, not why, the system allowed it to happen. It is the investigation stopping exactly one question too early. The real question is always the next one. Why did the system permit a single person to cause this? Which leads to the second point, and this is a principle I want you to internalize. If one person can cause the failure, the design is the issue. A control that depends on a single human never making a mistake is not a control. It is a hope. And hope is not a CPA strategy. Third, retraining as the corrective action. Retraining almost never changes the mechanism. Think about what stays the same after retraining. The same layout, the same sequence, the same tooling, the same time pressure, the same ambiguous step. The next operator walks into identical conditions. We have not fixed anything. We have just refreshed the person who happens to be standing there next. So what does strong look like? A strong root cause is scientifically supported. It answers why the existing controls did not prevent the event, and it does so with objective evidence rather than assertion. And a strong CPA changes a control. The design, the sequence, a system limit, an interlock, an added independent check. Something that actually lowers recurrence risk, not just awareness. Here is the question in the gold box, and I want you to actually do this exercise back at your site. Take your last 5 CAPAs. How many of them would survive one question? What control actually changed? Not what was communicated. What changed? If we're going to separate weak from strong, you need a way to score it consistently. So here's a rubric you can put to work tomorrow. This is a working tool, not a concept slide. I want you to think of it as a scoring sheet you can lay next to any investigation before QA approves it. 7 dimensions, and for each one, what weak looks like versus what strong looks like. Problem statement. Weak is vague. OOS occurred. Strong is specific. What, where, when, the magnitude, and the limit that was exceeded. If you cannot write a precise problem statement, you do not yet understand the problem. Investigation scope. Weak, this batch only. Strong, related batches, products, equipment, methods, suppliers, and trends. This is the dimension that most often separates a finding from a repeat finding. Root cause. Weak, operator error, or simply assumed. Strong, scientifically supported, and it explains why the existing controls did not prevent the event. Impact assessment. Weak, and please tattoo this one on your memory, met spec, so no impact. That single sentence is, in my experience, the most dangerous line in any deviation file. Strong is a reasoned conclusion about distributed product and in-process product, supported by evidence. CAPA. Weak. Retraining or an SOP reminder. Strong. It changes a control and targets the actual failure mechanism. Effectiveness check. Weak. None, or simply CAPA closed. Strong. A defined metric with data and a time frame to confirm it actually worked. And QA review. Weak. Signs for completeness. Strong. Challenges adequacy before approval. Read each row as a pair. The weak column is what reviewers see constantly. The strong column is the bar. The distance between them is your improvement plan. Let's prove the rubric works. I'm going to give you a real-shaped scenario, and we're going to score it together, out loud. Now we work. Here is an anonymized scenario, and I want the room engaged for this one. We are going to score it against the 8 questions on the right, together. The scenario. Over 5 months, 3 batches of the same product show the same impurity trending above its action limit, but still within specification. Each event is investigated separately. Each one concludes analyst technique, assigns retraining, and releases the batch because the results met specification. No link is drawn between the 3 events, and no review of the method, the column, the sample preparation, or the manufacturing process is documented anywhere. Take a moment and read it. Now let's run the 8 questions. What happened? What should have happened? How was the issue detected? Why was it not prevented? Could it affect other batches, products, equipment, methods, suppliers, or sites? What objective evidence supports the root cause? What CAPA addresses the actual failure mechanism? And how will effectiveness be verified? Let's find the failures together. First, the impurity is trending above the action limit. An action limit is, by definition, the level at which you are supposed to act. 3 times it was breached, and 3 times the action was retrain the analyst. Second, analyst technique is an unsupported root cause. There is no objective evidence offered for it. It is an assumption that conveniently closes the record. Third, met spec so released. Skips impact assessment entirely. That dangerous sentence again. And fourth, the headline. 3 linked events were treated as 3 separate one-offs. So where would FDA most likely open this? Take your votes. Root cause, impact assessment, or the failure to connect the 3 events. My experience says the failure to connect is the one that does the most damage, because it demonstrates the system cannot detect a pattern. And a system that cannot detect a pattern is exactly the failure chain we drew earlier, made real. That case lived mostly in the lab and the investigation. But the same looks fine isn't controlled problem shows up in production too. In processes we validated and then stopped watching. Let's talk about drift. Let's move on to the production floor. And I want to challenge a sentence I hear constantly, said with great confidence. But we validated that process. Good. Validation matters. But validation is not a permanent state of grace, and treating it like one is how controlled processes quietly drift. First idea. Validation is a point in time. FDA's process validation lifecycle thinking qualifies a process under defined conditions at a moment. It demonstrates the process can perform. It does not, by itself, prove the process stays in control for the next 2 years of routine manufacturing. Second, stage 3 is where drift is caught. Continued process verification, the ongoing stage, is specifically meant to detect drift over time. And in my experience, it is exactly where most programs are thinnest. Companies pour enormous effort into the initial qualification and then put ongoing verification on autopilot. Third, and this is the reframe that matters most, met specification can hide a trend. A batch can pass every single test while the process moves steadily toward failure. Specification is a floor. It tells you that you have not fallen through it yet. It is not, on its own, evidence of control. A process can be entirely within spec and entirely out of control at the same time. Look at the common drift sources on the right, because these are concrete and they are sneaky. Undocumented, small changes that accumulate over time. Weak or unmonitored in-process controls. Perfunctory batch record review. Signing without seeing. Raw material and component variation that creeps in through suppliers. Equipment wear and deferred maintenance. And thin, continued process verification tying it all together. None of these announces itself. They add up quietly until a batch finally falls through the floor, and then everyone is surprised, even though the trend was visible for months. If passing spec isn't proof of control, then what is? Let's get concrete about the evidence that demonstrates a process is still in control. So if all the batches passed is not sufficient evidence of control, what is? The answer is on this slide, and the key word is integration. Look at these 8 data streams: batch yields and trends, in-process results, deviations, complaints, out of specification and out of trend results, maintenance history, environmental data, and stability data. Here's the thing, your site already collects every one of these. None of this is new data you need to go generate. The problem is that these 8 streams almost always live in separate systems, get reviewed by separate people, in separate meetings, against separate thresholds. A process that is genuinely in control shows stable, predictable behavior when you read these streams together. Not 8 isolated all-clear reports, one coherent story. The deviations, the yields, the environmental data, and the stability results all pointing the same direction. That is what control looks like as evidence. Which brings us to the discussion question, and I want you to sit with it. What evidence would convince FDA that this process remains in a state of control? Notice what the strong answer is not. It is not every batch met spec. The strong answer describes trended evidence over time, against defined limits with a named owner who is actually looking at the integrated picture. All batches passed describes the floor. Here is the trended, integrated, owned evidence describes control. Everything we've said about evidence assumes the underlying results can be trusted. So let's go where that assumption gets tested hardest, the laboratory. The laboratory is where a single finding can do disproportionate damage. And I want to explain why before we get into the structure. First, controls must be scientifically sound. 21 CFR 211.160 does not just require that laboratory controls exist. It requires that they be scientifically sound and appropriate. That word sound is the bar. A control that is present but cannot be scientifically justified still fails the test. Second, and this is what makes the lab so high stakes, a lab finding rarely stays in the lab. The moment a result is shown to be unreliable, it raises a much larger question. Which of our past results can we still rely on for release decisions? One questionable method or one compromised dataset can cast doubt backward across months of releases. The blast radius is enormous. Third, a lab finding usually reflects the system, not the analyst. When you look underneath, the pressure points are systemic. How out-of-specification results are handled, the logic and justification for retesting and resampling, method suitability, sample identity and handling, QC capacity and throughput, and review backlog. These are governance and design issues. The analyst made a mistake is almost never the real story, and treating it as the real story is how the finding comes back. Look at the list on the right of where lab systems get pressured. Out of specification handling and invalidation discipline. Are results being invalidated with real justification or with convenient justification? Retest and resample logic. Method and system suitability. Sample identity, handling, and stability. QC capacity and review backlog. Because a backlog is a quiet pressure that produces shortcuts. And stability scheduling, delays, and failures. Every one of these is a system question, not a personnel question. If a reliable result depends on the whole system, it helps to see that system as layers. Here are the 4 control layers that make a QC result trustworthy. Here's a structure the QC managers in the room can actually audit against. A trustworthy result rests on 4 control layers, and the critical thing to understand is that they are sequential dependencies. A failure in any one invalidates the result, no matter how strong the others are. Layer 1, method control. The method is validated, suitable, and current, and system suitability is enforced before any result is allowed to count. If system suitability fails and the run proceeds anyway, nothing downstream matters. Layer 2, sample control. Correct identity, integrity, handling, and chain of custody from the point of sampling all the way to the bench. The most elegant method in the world applied to the wrong or degraded sample gives you a beautifully precise wrong answer. Layer 3, execution control. The test is performed as written, and deviations and anomalies are captured at the bench, in the moment, not reconstructed afterward from memory when someone asks a question. Layer 4, review control. And this is the layer where firms most often coast. Second-person review and data and audit trail review that genuinely detects problems, not a review that merely confirms the paperwork is present. Real review is a detection step. A signature is not review. Now, read the strip at the bottom. Out-of-specification governance sits across all 4 layers. Consistent with FDA's out-of-specification guidance, a result is only as reliable as its weakest layer. A sound method cannot rescue weak review. Rigorous review cannot rescue a compromised sample. This is precisely why the method is validated is never, by itself, a complete defense. It is one layer out of 4. All 4 of those layers produce one thing: data. And if the data itself can't be trusted, every layer above it collapses. So let's talk about the quiet amplifier of every GMP risk: data integrity. Data integrity has a branding problem. When people hear it, they think of the dramatic cases: falsified records, deleted failing results, deliberate fraud. Those exist, and they end careers. But if you only think about data integrity as a fraud problem, you will miss where the real, everyday risk lives at most sites. First point. It is usually a design issue, not misconduct. Consistent with FDA's data integrity guidance, the majority of data integrity gaps come from how systems are designed and used: access controls, audit trail configuration, workflow, rather than from anyone deliberately cheating. Shared logins because it was easier, audit trails that were never switched on, or are on but never reviewed, an unvalidated spreadsheet doing a critical calculation. None of that is fraud. All of it is a data integrity finding waiting to happen. Second point, and this is the strategic one: data integrity amplifies every other risk. It is not just one more module sitting alongside investigations and process control. It is the layer underneath all of them. If the data behind a decision cannot be trusted, then every decision built on that data is in question. The release, the investigation conclusion, the stability trend, the process control story we just spent 2 modules building. That is why I call it the hidden amplifier. It does not just create its own findings, it multiplies the seriousness of everything else. Look at the design factors FDA actually probes on the right: access controls and unique user privileges. Can you tell who did what, or does everyone share one login? Audit trails: enabled, reviewed, and meaningful, not just technically present. Trial and test injections and aborted runs, the classic place where inconvenient data quietly disappears. Backup, archive, and data retention. Spreadsheet and standalone instrument validation. And raw data review, not just summary review, because the summary always looks clean. The story is in the raw data. So the practical question becomes simple to ask and hard to answer. Can your records actually prove what happened? That's the test on the next slide. Most of you know Alcoa Plus, so I am not going to lecture you on the acronym. Instead, I want to use it the way it is meant to be used: as a checklist you run against your own records, and then as a single test question that operationalizes all of it. Quickly, data must be attributable. You can tell who did it. Legible. You can read it. Contemporaneous. It was recorded when it happened, not reconstructed later. Original. It is the true source record, not a convenient copy. And accurate. Then the plus: complete, consistent, enduring, and available. 9 properties, and trustworthy data holds all of them at once. Now collapse all 9 into the test in the gold box, because this is the version you will actually remember under pressure. Can we prove who did what, when, why, using which system, and whether the original data remained complete and unchanged? If you can answer that fully for a given record, you have Alcoa Plus. If you cannot, you have a gap, and you have just located it. But here's the line firms miss, and it is at the bottom for a reason. Alcoa Plus only becomes a real control when management actually reviews audit trails on a routine basis. A principle that nobody verifies is decoration. It is a poster on the wall. Routine, documented audit trail review by people with authority is what turns it into an operating control. And tie this straight back to the amplifier idea. If the honest answer to the test question is not fully, then the data underneath every release decision is, to some degree, in question. What the experienced audience won't have heard framed as a principle nobody verifies is decoration. We've covered the lab and the data. Now to a place where the records can be flawless and the site can still be out of control: cleaning and maintenance. This module is about one of the most counterintuitive gaps in GMP, and it is captured perfectly by the title. When the records say clean, but the conditions say otherwise. Start with why cleaning and maintenance are linked in the first place. 21 CFR 211.67 ties them together deliberately because both of them control contamination. They are not two separate housekeeping chores. They are two halves of one contamination control strategy. And that means a complete, signed cleaning record over a poorly maintained or genuinely hard to clean piece of equipment is not contamination control. It is documentation of an activity that the equipment defeats. Here is the framing line I most want you to take from this slide. Clean on paper is an execution and design gap, not a documentation gap. Fixing the logbook fixes nothing, because the logbook was never the problem. If your CAPA for this kind of finding is improve the cleaning records, you have aimed at the wrong target entirely. Now read the scenario on the right with me. The cleaning logs are complete and signed for every single changeover, flawless paperwork. But during the inspection, there is visible residue on product contact surfaces. A vessel that was signed off as cleaned shows scoring, a roughened surface that physically traps material and that no amount of cleaning per the current procedure will reach. And a hard-to-reach valve is not addressed anywhere in the cleaning procedure at all. The records and the conditions flatly disagree. And here's the part that matters. FDA trusts the conditions. The signed log proved only that someone executed a procedure the equipment design defeats. This is the same lesson we learned in production, in a new setting. Doing it once isn't keeping it controlled. Let's separate cleaning validation from cleaning control. You will notice this mirrors the process validation point from earlier, and that is intentional. It is one of the deepest themes of the whole session. Validation proves capability. Control proves that the capability persists. Two different claims. On the left, cleaning validation. It demonstrates that the procedure can work. It is done under defined worst-case conditions. It establishes acceptance and residue limits. It uses qualified analytical recovery methods. And this is the key phrase. It is a point-in-time demonstration. At the moment of validation, under those conditions, the procedure was shown to be capable. On the right, cleaning control. This proves the procedure keeps working in routine, day-to-day use. And it is a living program. Equipment design and cleanability, visual inspection limits and verification, the hard-to-clean locations and dead legs that the validation protocol may never have sampled, dirty hold and clean hold times, microbial and environmental trends, and maintenance-driven contamination risk as equipment ages and wears. Think about what validation simply cannot account for. It cannot account for a surface that becomes scored 18 months later. It cannot account for a deferred maintenance issue that changes how a part seals. It cannot account for a dead leg the protocol never reached. All of those are control questions, not validation questions. So, the distinction that matters in the strip at the bottom. Validation is a snapshot of capability. Control is the ongoing evidence that the snapshot still holds. A validation report on the shelf tells you what was true on the day it was signed. Control tells you what is true today. Nowhere is the you can't test it in, you have to build it in principle clearer than in sterile and aseptic manufacturing. And even if you don't make sterile products, the lesson travels, so stay with me. Even if half this room never touches a sterile product, do not tune out. Because sterile manufacturing exposes the logic of contamination control more clearly than anything else. And that logic applies everywhere. I will make the bridge explicit at the end. FDA's aseptic processing guidance and 21 CFR 211.113 expect an integrated contamination control strategy. Not a single final test you lean on, an integrated strategy across many elements. Let me walk the 6. Environmental monitoring, and the key word is trends, not single passing days. One good monitoring day proves very little. The trend over time is the signal. Personnel interventions, frequency and type, because in aseptic processing, people are the single biggest contamination route, and every intervention is a risk event. Gowning behavior, qualified, observed, and actually sustained in practice, not just certified once a year. Media fills, designed to genuinely challenge worst-case aseptic operations, not to comfortably pass. Sterilization validation, demonstrated lethality and proper load mapping. And container closure integrity, sterility maintained all the way through shelf life, not just at the moment of fill. Now the punchline, in the dark strip. Final sterility testing cannot test in sterility. Its sensitivity is genuinely limited. A test on a small sample of a batch simply cannot detect low-level contamination reliably. So sterility has to be built in and continuously demonstrated, never inspected in at the end. And here's the bridge for everyone who does not make sterile products. That sterile discipline, monitor, then trend, then intervene, then prove control, is exactly the discipline that demonstrates a state of control anywhere in manufacturing. Sterile operations just make the consequences of getting it wrong impossible to ignore, so the discipline is more visible. The logic is identical for your tablets, your API, your device. That closes our 7 deep dive modules. Now, let's convert all of it into tools you can carry out the door. First, a way to translate FDA's own language. This is one of the highest value things you will take from today. And frankly, it is part of why a session like this earns its keep. FDA's language is remarkably consistent. Once you learn to translate it, you can read any 483 or any warning letter theme and immediately understand what the agency actually suspects underneath the phrasing. This is a translation table. The phrase on the left, the operational weakness it usually signals on the right. Failed to thoroughly investigate signals a scope, root cause, impact assessment, or CAPA weakness. Not scientifically sound means FDA wants objective evidence, not assumptions. They are telling you your justification was assertion, not data. Procedures were not followed points to an execution and oversight failure. Inadequate response means your CAPA did not reach the systemic root cause. You treated the symptom. Then the ones that should make you sit up. Retrospective assessment requested is the tell that FDA already believes the problem is broader than the single-sided event. They are asking you to go look across your other product because they suspect what you will find. Quality unit is inadequate means governance failed to detect or prevent recurrence, the parent finding we talked about in Module 1. And data integrity remediation requested is the most serious of all. It means FDA no longer trusts the records supporting your product quality. When you see that phrase, the conversation has fundamentally changed. The skill here is translation, and it runs both directions. You can read their language to understand their concern, and you can use this table proactively, self-diagnosing your own systems against these phrases before an investigator ever has to write one of them down. Reading the language is diagnosis. Now let's talk treatment. 2 tools for building CAPA and prevention that actually hold up. 2 reusable tools on this slide. The first, on the left, is the CAPA strength test, and it is really the operational version of everything we said in the investigations module. A strong CAPA can answer all 6 of these questions. If it cannot answer all 6, it is not finished, no matter what the due date says. What control failed? Why did the existing system allow the failure? What control will change? Not what will be communicated, what will change? How will the site know the control is working? What data will be trended to prove it? And who owns escalation if recurrence appears anyway? 6 questions. Run any proposed CAPA through them before approval. And the weak ones expose themselves immediately, usually at question 1 or question 3. because retraining cannot answer what control changed. The panel on the right is deliberately not a timeline, and I want to be very direct about why. You have all seen the 30, 60, 90-day roadmap slides. I am not going to give you one, because a fixed calendar promise is the wrong tool. Remediation is risk-based, not date-based. So you prioritize by what actually matters. Patient and product risk first, then repeat occurrence, then detection weakness, then systemic impact, then regulatory exposure. And then you sequence that prioritized list against your real constraints, practical feasibility, your site's maturity and resources, and product complexity and legacy systems. Read the line at the bottom, because this is the honest, defensible position. Higher risk issues may require escalation, and structural remediation may need phased implementation, depending on product risk and site maturity. No fixed 30, 60, 90-day promise fits every firm, because firms differ enormously in size, risk, legacy systems, and resources. A framework that prioritizes will serve you far better than a calendar that pretends every problem takes the same amount of time. We've built the diagnosis and the treatment. The last tool turns all of it inward, a way to pressure test your own system before anyone else does. This is the tool I most want you to actually use, because it converts the entire session into 6 honest questions. Each one maps directly onto a module and onto the failure chain we drew at the start. And the instruction that makes it work is this: answer them on real, recent examples, not hypotheticals. Oversight. Can QA actually produce, a case where it challenged a weak investigation in the last quarter? Not we would, show me one. Detection. Which failures would your system catch on its own, without an inspector pointing them out? Investigation. Do your investigations reach related batches, products, equipment, methods, and suppliers? Or do they stop at the 4 walls of one event? CAPA. Can you name one control that changed, with trended evidence that it actually worked? Data. Could you reconstruct who did what, when, and whether the original data is intact? And recurrence. Who, name the person, owns the view of repeat risk across departments, lines, and sites? Here's how to run it. Do not do this in the abstract. Pull last quarter's actual deviations and investigations, and try to answer each of these 6 questions with real evidence in hand. Wherever the honest answer is, we couldn't actually show that. Congratulations, unpleasant as it feels, you have just found your inspection vulnerability before FDA did. That is the entire promise of today made concrete. Find your own gaps first, on your own terms, with time to fix them. And notice, every one of these 6 is answerable. There is nothing exotic here. The only question is whether you have the evidence or only the intention. Which brings us to the one idea I want you to walk out the door holding. Let's close. Let me bring this all the way back to where we started, and then I will let you go. Here is the sentence the entire 90 minutes has been building toward, and I want to read it to you carefully. FDA does not only ask whether a procedure exists. FDA asks whether the firm's quality system can prove control, detect failure, investigate scientifically, assess impact broadly, and prevent recurrence. Read that again on your own later. Every module today was one of those verbs: prove, detect, investigate, assess, prevent. And the durable lesson underneath all of it: sustainable GMP compliance comes from everyday control, not from inspection preparation. Compliance is not a project you switch on 3 weeks before an audit and switch off afterward. It is the ordinary, unglamorous, everyday operation of control, detection, investigation, impact assessment, and prevention. The firms that never seem to scramble before an inspection are not lucky. They are simply running the system every day that everyone else tries to assemble at the last minute. You now hold 6 working tools: the failure chain, the investigation rubric, the FDA pattern library, the CAPA strength test, the risk-based prioritization, and the self-assessment. Please do not let them become slides you file. Use them on your own system, on real examples, this month. That is the difference between having attended a webinar and having changed something. So here is the whole thing in 5 words. Build systems that can prove control. Not systems that look compliant, systems that can prove it. Thank you all. And as a final reminder, everything today has been educational and is not legal advice. I would be glad to take your questions.